Do you have a neck that feels heavier than it used to? A brow that has dropped so low you look tired even when you're not, or cheeks that seem to have just shifted south? Today, we're talking about all three with one of Manhattan's most respected facial plastic surgeons. And we're following a question that is reshaping surgery right now: traditional approaches versus endoscopic, where a camera guides surgery from inside the body. Which is better? And is it better for every area of the face? Stay with us all the way to the end because Dr. Sterry is going to be honest about one type of facial surgery that most surgeons will not say out loud. And it's the kind of honesty that protects you. Dr. Sterry, tell me about a neck that really stayed with you, a patient whose neck told you something important about what is actually possible.
The first one that comes to mind, and there are several, but I think the first one was actually a very young patient. She was 25 years old. And she had sort of a full neck. And she told me that she'd had it as long as she can remember. It didn't matter what her weight was. And she told me that most of the women in her family had a similar neck with just a bad cervical mental angle, meaning her neck seemed to hang very full. Uh, and she came in asking for some chin liposuction. And I pretty quickly explained, I don't think that's going to cut it here. We need to sort of change your architecture in order to give you the result you want. What she wanted was a nicer profile. So we did what we call a midi neck lift. You'll sometimes see it described as a deep neck lift. But essentially, there's a 1 inch incision behind the chin crease here. And we go underneath the muscle that's immediately behind the skin. And there's a sort of a significant triangular, sometimes diamond-shaped fat pad underneath there. And I removed that. In her case, it was quite generous. And then I tightened a couple of different layers of muscle, and I actually reduced some of the muscle in the area because it was sort of bulky. And in her case, I also reduced some significantly large salivary glands that are located right about here. And the combination of those maneuvers gave her a much nicer profile, a much nicer angle, and she walked away looking like she was 25 instead of 45. She was very happy and grateful, and she let us use her photographs and Instagram and things like that. Um, and she really stuck with me because she thought she was afraid she was doomed for the rest of her life to have this appearance, and she was actually a pretty fit young woman. There was no reason for her to live that way. She has a lot more confidence now. She feels much better about herself. And apparently she gets a lot more attention. She tells me she can't buy herself a drink at the bar anymore.
That's amazing. That's amazing that what you do can be such a confidence builder.
Yeah, it's really satisfying that way. It's a lot of fun.
I love that. I love that about being in this community. Dr. Thomas Sterry is a board certified plastic surgeon, a fellow of the American College of Surgeons, and the past president of both the New York State and New York Regional Societies of Plastic Surgeons. His practice is on Fifth Avenue in Manhattan, just across from the Guggenheim. Coming up, he's going to tell us one thing about the neck most surgeons will not discuss in a consultation. And stay with us all the way to the end because he's going to be honest about one type of facial surgery where the long-term results are still not proven. Dr. Sterry, welcome to Beauty Seek.
Thanks so much for having me. This was a lot of fun.
Most people assume the neck is one of the easier parts of the facial area to treat. On a scale of 1 to 10, how difficult is the most challenging neck to correct?
It's a 10. The neck, I personally believe that the neck is the secret to a good facelift. And there are so many different components in the neck. If you think about the moving parts to keep your head, straight and moving around, and stable, there's a lot of different parts involved, and any one of them can create problems. For instance, people who develop those neck bands, those are called platysmal bands, that is really tough to get rid of. There are some good ideas. Everybody's got a theory. I have my own. We never promise to get rid of those completely. We usually tell folks we can reduce them dramatically, but they may not go away forever. They're really tough those suckers to get rid of. The I mentioned a minute ago, reducing some of the girth of the other muscles, that's called the gastric muscle, can make a big difference. But the biggest and probably most controversial area to this day in neck surgery, cosmetic neck surgery, is the treatment of the submandibular glands, which rest right about here. And some of us are willing to tinker with them and kind of shave them down. And what we want to do is trim them back to a point where they're no longer obscuring a beautiful jawline. When we're younger, they live up behind the mandible. And as we age, they get larger and they seem to dip down a bit. So when we shave those down to a point where they're not showing, it can make a dramatic difference in the way someone looks. And this is an incredibly powerful move. And yet a lot of my colleagues aren't really willing to do that procedure.
I was speaking with Dr. White about the same thing the other day, and he was saying that some surgeons will even like inject Botox to try to shrink them. Is that a
Yes,
valid?
that's the thing. It's a little bit tricky. It's hard to find. You need to be pretty slick with your ultrasound. But that's only a temporary measure. I kind of have a little bit of resistance to it for a few reasons, including the gland. One of the main reasons the surgeons are nervous about going near it is that it bleeds pretty profusely. And I'm not necessarily wanting to put something sharp into it if I can't touch it and feel it and control the bleeding that I might cause. So yes, those things are done. I think the odds of a problem are pretty low, in fairness to Dr. White. I'd rather just do something definitive and take care of the problem. If I'm doing a neck lift anyway, and I'm looking at the gland, I'm going to reduce it, most likely.
Okay. It sounds like a scary thing, but yes, in the right hands, it can be a beautiful result.
Well, I think that a lot of us, unfortunately, a lot of surgeons, they rely on their training that they had years ago. And if they weren't trained to do a particular maneuver, they may never learn that skill. So you do have to be willing to go and get the cosmetic goods. You have to go to the boutique courses and anatomy labs, things like that, and learn the proper technique so that you, as a surgeon, feel safe and confident during the procedure. Short of that, I don't think that people should address it willy nilly. So the folks that aren't willing to, I understand. I don't tell anybody that they should. But what I do say is that they should learn about it and then decide whether or not they want to do the procedure. Um, when someone never was trained and doesn't know how and says that they simply won't, I think that's sort of closed-minded.
Okay. So a question that a beauty seeker could ask a surgeon if they are watching this interview and they're learning about shaving down those glands might be, have you been trained in this? How often have you done this?
Well, yeah, I think that's a probably reasonable question. I think that the one question a lot of patients really should ask the surgeon about any procedure is, how often do you do this? How many have you done? That sort of thing. Were you trained in this area? There are, I hate to say such things, but there are folks kind of practicing outside of their training. And that's a little bit bothersome, right? You'd like to know that they've been there before, that they're confident, that this is something that they do every day like bread and butter. Um, that certainly is something that patients should know about the surgeon who's about to perform their operation.
And on that vein of thought, you performed over 1,000 chin and neck liposuction procedures, more than many surgeons, I would guess. On a scale of 1 to 10, how much can liposuction alone improve the right neck?
Well, the key is that last part, the right neck. When someone has a lot of subcutaneous fat in this area, it can make a tremendous difference for the right person. And yes, we've done, actually, we just counted these last week. We've now done 1,091 chin neck liposuction cases. And, I'd like to think that they're all happy. I can tell you that the vast majority are very happy with their outcomes. So it can make a nice improvement in the right person. That doesn't mean that it's right for everyone. Sometimes the challenge that I have as a surgeon is helping patients understand their own anatomy and why liposuction might not be the right procedure for them. And it's a little bit hard to accept sometimes. I have to sit down and really get into at a granular level the anatomy and what I'm thinking and why. Because at the end of the day, I want them to be happy. They need to walk away glad that we met. The old saying, if they don't look good, I don't look good. So it's really all about me, right? I'm just protecting myself. I just really need them to look great when we're finished.
Definitely. You protect the patient, you protect yourself. Can you give us one reason why it might not be a good procedure for the neck, liposuction?
Oh, sure. You heard me describing the anatomy a minute ago. The truth is, sometimes people don't have that much subcutaneous fat. In other words, fat right behind the skin, and yet they still seem to have a full neck. And sometimes that is fat that is deeper. It's underneath that first layer of muscle, which is called platysma. Sometimes, especially in men, I notice that their neck might have a lot of girth because they're muscular. And the way to fix that is to tighten up the muscle, or sometimes to reduce the muscle, as I mentioned before. Um, they they won't miss it. It's not the sort of thing that is a horrible sin. Everybody acknowledges that. But these things can be done, and liposuction in those patients is not only a waste of their time and resources financially, but it also can be a disservice from a cosmetic perspective because I've had, oh gosh, any number of young women, um, and middle-aged women for that matter, come in asking for chin or neck liposuction. And I'll say, look, if I suction this neck, you're going to have every reason to be angry with me because I'm going to give you old lady skin. You want to have a little bit of fat behind the skin because that's what gives the skin some life, some turgor, some pizzazz. It really is very healthy looking. If there's no fat behind there, it kind of looks creepy and it loses its liveliness.
Yeah, it just seems like there's so much education, and then at the same time, there's not enough where we come in, we beauty seekers come into professionals like you, and we think we know what we need. And then you have to talk us out of it.
Yeah, because they've done some research and that's quite right. Maybe even used AI, but they're pretty convinced that this is what's going to solve their problem. And then when they meet me, if I disagree with the AI or Google or whatever, that can be a little disconcerting, and it's hard sometimes for them to accept it. But listen. I've had God knows how many patients walk away. I didn't operate on them, and I just hope that they didn't walk into the next office with someone who was willing to do it because I felt strongly in those instances that it was a mistake. Believe me, I'd rather operate than not. I love my job, but if it's the wrong move, it's the wrong move.
Thank you. Yeah, I appreciate knowing that. I appreciate hearing that from surgeons that I interview. If I feel it's a no, I'm gonna have to say it's a no.
Yeah, that's the thing. Having been in this business for a minute, yeah, we're no is sometimes the best answer. Yeah.
Great. Let's dig into the men for just a moment here, a little bit deeper. So men who are very fit, those bodybuilders, athletes, they often have that neck, with a lot of muscular bulk rather than fat. We talked about that as we were prepping for the interview. How achievable on a scale of 1 to 10 can you get more of that chiseled jawline for that type of neck?
Yeah, so some of this depends on how they're built. Muscular is one thing. If they also have a lot of fatty tissue, because there's one thing to be powerful, but still have a high fat content, and it's another thing to be incredibly lean. In either case, we do have an answer for those guys because they do tend, in general, to be more lean, as I was saying. Um, if there's some fat, for instance, around this area is called the gonial angle, and everybody wants this to be nice, squared off, and clean. So we can still do a little bit of liposuction over there for some of these guys, but for those people who are particularly muscular, as you're saying, yeah, when we go in through that incision behind the chin crease, we dip underneath the platysma muscle, and it's almost always that that digastric muscle. There are two of them right here, and they can be really large, especially if these are guys who are working out with weights and doing resistance training, because every time they kind of Valsalva and they really exert themselves, those muscles get tighter and they become hypertrophic. And so the way to handle that is to literally split the muscle and take 50% of it or so away sometimes. It depends, of course, on each situation. But that's the only way that they're ever going to get a nice, clean profile, because otherwise the bulk of the muscle is hanging down below the mandible. And it can be done, to get back to your question, but it takes some doing, and you need to have somebody who's been there before and is willing to make those maneuvers.
Okay. So if they're very lean, is it more achievable, or if
In
they have,
general, yeah, I would say in general, if they're more lean, it's better. Because the truth is, if they have a high, if they're very muscular but have a higher fat content, all right, so then I go ahead and do some liposuction anyway and take out some of the deep fat and we move on.
if a patient is sitting across from you for a neck consultation, what is the one question that you think is probably the most important thing that they never think to ask?
Yeah, I think I already alluded to it. I really think that one should ask, how many of these have you done? Is this a major part of your practice? How many did you do last month? That sort of thing. You really want to know that this is something that the surgeon is completely fluid with, that they're really articulate in the area, and they have done this many times, and they're not really hesitant. They're not nervous. It's another day of work. That's all.
Yeah. Okay. That's a good point. The math of it. I talked to Dr. Zachary and she said, don't just take the number, do the math. How many have you done in a month, in a week, and frequently?
Yeah.
Beauty seekers, here's what you just learned. The neck is all about structure. A younger patient can look decades older because of that structure, and structure can be addressed at any age. Let's talk about scars. What is the approach or technique that would kind of result in maybe the least visible scar?
Oh, well, without question, if it's possible and they're a good candidate, chin neck liposuction is almost scarless. I use a pinhole incision behind each earlobe and a crease behind each earlobe, which those essentially disappear. The patient will never see them. And then I make one in the chin crease here, which can leave a little freckle. A year later, if you look for it, you can find it, but you're going to have to look for it. It will not be obvious to anyone. So that's clearly the simplest, easiest, most invisible procedure to do, which is one of the reasons I've done it so many times. I mean, it's a great answer for the right person.
Perfect. I didn't know that you go in behind the ear. That's fantastic.
Yeah, so you could triangulate like so, and as I was saying, kind of accentuate the gonial angle, and also triangulation in liposuction is kind of a basic principle to help to prevent grooves and divots and dents and things like that. You kind of cross hatch all the areas that you want to treat all the way across the neck.
Dr. Sterry, can you talk about incisions and a little bit about the technique with a necklet, please?
Well, sure. So there's a couple of different ways that a necklet might be done. There's a couple of different incisions. Sometimes with a formal necklet, where we have excess skin that we want to reduce, we make an incision behind the ears and into the hairline so that we can sort of redrape the carpet and bring this tissue back. But anytime we want to do a necklet where we're getting into the deep space, we make an incision over here someplace. It's usually about an inch long. Some of us make it right behind the chin crease, as I do, because position-wise, it helps us to get into a more advantageous position. Some folks will put it into the chin crease itself. And, there's some minor debate about all of this. If you put the incision into the chin crease itself, the argument is, okay, well, they won't really have an additional scar exactly. And I get that, but it does have to be longer because you're trying to get down into the same area, and just mechanically trying to get into the deep neck space, it's a little bit more difficult. So I was trained to make the incision about a centimeter or two back behind the chin crease. And if the neck lift is done well, you end up lifting all this tissue anyway, and it becomes sort of horizontal facing the floor. It's in a great spot that is very hard to find. And that skin, that tissue usually heals like with a hairline incision. And so we don't really stress too much about it. Um, there is a mark, of course, but it's not really much worth talking about. So there are different styles, different ways to do these things. But that's the way that I make my incision.
Now, are you doing that endoscopically or not?
From the side, I sometimes will go endoscopically if I don't want to make, depending on how the patient's built. I can make an incision just behind the ear, like we have I told you to watch behind your ears, eye area, right in the crease where your ear meets your skull, and and you can use the scope to get in down into the neck area here, and that can be very helpful. Yes, if the patient doesn't need skin redraping. If they need redraping, you might as well make the incision because you got to do it anyway. Um, in fact, not to change subject, but we can use that same incision with an endoscope to get into the lower half of the face proper as well.
Perfect. Love it. Beauty seekers, here's what you just learned. Neck liposuction for the right patient can produce a significant result with hardly a visible scar at all. And the submandibular gland is the thing that most surgeons, they probably will not discuss in a consultation. Dr. Sterry reduces it, and for the right patient, it can change everything. Dr. Sterry, most patients leave a neck consultation never having heard the word submandibular. You changed that for me and for the Beauty Seek community. Thank you for educating our community.
You're very welcome.
Dr. Sterry, endoscopic brow lifting is getting a lot of attention right now. Can you explain what that is and the benefits to a beauty seeker like me?
Yeah. So with an endoscope, we can shape the brow and sometimes lift it. It's not. It doesn't always have to be a lift. Sometimes we're focusing really on just changing the shape of the brow through very small incisions that are well within the hairline. Now, in the old days, say in the 80s, the only way we really had to perform a brow lift was to make an incision like so. It's called the coronal approach, and literally fold the skin down, tinker with the muscles, pull it back up, cut out a bunch of hair bearing area, and close. Um, that is quite old fashioned, and there are very few people that would have need for that anymore. In the mid 90s, the endoscopic brow lift came along, where there were small incisions inside the hairline, and using the instruments that I described with the endoscope, we were able to lift the brow and sort of suspend it a little bit higher. The problems that we ran into were several fold. One, it was way too easy to move the middle portion of the brow, and that's why so many people walked around looking surprised all the time. That was obviously not a cosmetically great look. The other thing was the suspension of the brow and getting it to stay in place. That we used to use screws in the skull. There's all kinds of drill holes in the bone and suture techniques and whatnot. And that really gets to be a little bit frustrating. The big knock on this procedure, and you get right around the year 2000, 2001, I think, was that it didn't hold up. That, you go through all this effort and it lasted about 18 months, and then the patient's brow was back down where it was before. What we think was, in retrospect, what we think was going on is that there was an incomplete release of some of the attachments all along the orbit here. And so nowadays, the thinking is that if you make sure with the scope, if you know what you're doing, and you make sure that you release this zone, then you're able to get a nice elevation and you almost don't need any suspension. In other words, once the release is done, you sort of put the tissues where you want them to be, and they tend to stay there a lot longer. And it seems like this is really starting to take hold, and there is a lot more research nowadays proving that this is the case.
I didn't realize the endoscope had been around since the 90s. Did I hear that correctly?
Yeah. Oh yeah. This is Renato Saltz and a couple of other folks. They were really trying to develop this and tinker with it and get it right back in the 90s.
Because you're actually putting a camera inside the body?
Well, you're putting the camera is actually at the back of the scope, and then there's a fiber optic piece with the lens at the tip that goes underneath the skin. So the camera, the bulk of the camera, is still outside the body, but the lens is long as think of it as a long tube, a long piece of glass, and that's why you can see what you're doing from far away.
Okay, thank you. That makes sense.
Yeah.
Dr. Sterry has been awarded excellence in teaching by his surgical residents at Mount Sinai, not once, but 3 times. And he just told us why the original endoscopic brow lift approach failed and the one thing that changed everything. Now stay with us because at the very end, he's going to tell us about one part of the face where he's still watching and learning about the results of an endoscopic surgery. Dr. Sterry, welcome back to Beauty Seek.
Thanks so much for having me.
A dropped brow changes the entire upper face. How much does brow position affect the way the patients that you visited with and worked with, how does it affect their self-perception and themselves about aging?
That's a tricky question because I'm not sure people realize how much it affects their perception of themselves. People don't pick up on that. Many times people think that it's their upper eyelids that are the problem and they don't realize that it's the brow. So that's why it's a little bit tricky for me to answer. But it clearly, if you look at some before and afters, it clearly rejuvenates folks and really can make someone look much more like themselves, 10, 15 years ago. Lifting the brow, especially the lateral portion of the brow here that we call this the temporal brow, it makes a huge difference in how someone comes across and their age and their vitality, if you will.
Okay. This is all very interesting because I got an upper lip years ago. And while I was I think it was the day before I was getting the surgery, the surgeon was trying to get me to do, an upper brow lift and I couldn't see it. Well, he was holding one eyebrow up and I just was like, I have not done enough research on this, but, it sounds as though, it could have beautiful results and maybe I didn't need the upper lip. I needed the brow lift.
Uh, that happens more times than you may think. Sometimes I've had the experience where, despite my advice, I was I agreed reluctantly to perform upper lip blepharoplasty and take away some of the skin that was cutting. And what happens is that their eyes don't look much different afterwards, but the wrinkles on the forehead go away because they're no longer lifting their brow like this, trying to keep the lid skin off of their eyelashes. It's called compensated brow ptosis. This is a real thing. I see it regularly. I have it myself, so I know quite a bit about it. And it really is an issue. So, when you ask me on a scale of 1 to 10, how much does it affect? Well, I don't think people are really aware of it. You just gave us a great example in your own face.
It's an unknown. Yeah, I had no clue. Okay, that's fair. We're gonna have to dig into this someday here. Um, okay, as you said, the original endoscopic brow lift it got abandoned by many surgeons because results didn't last. But
I
then,
think people got frustrated. They got frustrated by the longevity. They got frustrated by the need to maintain so much equipment. The endoscopic equipment is bulky and bothersome. And then it also, in fairness, the public kind of gave it a bad rap because there were so many people walking around with a surprised look. So more and more people said they would never have a brow lift, not realizing that a well done brow lift can be very nice.
so do you think then that had to do more with the technique or the vision of what the brow lift could be?
I think it was the technique. So the folklore in this area is that there was a paper written right around 2000 or I think it was 2001 actually, happened to come out of a New York hospital, and they basically said, this technique doesn't really work. We're just going to do these open. It's not worth pursuing. From reputable surgeons, very reputable surgeons. And the scuttlebutt is that they weren't really completely releasing the ligament over here on the side of the orbit, and that's why their results weren't lasting. So the real hardcore endoscopic brow lift people started to refer to this as the New York ligament because it sort of killed their procedure and they blamed the New York surgeons. Again, always remembering I'm a New York surgeon. Um, but this is the, as they say, the lore of what went on. How much of this is true? Hard to know for sure. I wasn't in the operating room, but this is what we talk about.
Okay. Now, do you perform more of a modified brow lift?
I do. Generally speaking, I do. I am very intrigued by Fausto Viterbo's work on the gliding brow lift. I also appreciate Alan Matarasso's point about a little bit of skin removal. And so I actually perform a procedure where many, not every time, but many times, where I'll make a hairline incision here, undermining the skin, elevate the brow to exactly where I want it to be. And then Viterbo and Andre Auerswald demonstrated to us that we can sew the skin and the brow down to the exact place we want it to stay, leave those sutures in for a few days, and take them out before they start to leave marks. Uh, and the longevity is surprisingly good. When you see some of these blinding brow lifts compared to some other folks, depending on their technique, the longevity is terrific. I mean, years later, the brow really does stay where they wanted it to go. I have my own little theory about that. I think it's because you're no longer trying to fight against the musculature that's constantly pulling our brow down and bringing everything lower. So what we're doing is basically just resetting the area that the brow, the hairs in the brow and the skin here intersect with the muscle. So the muscle can go to hell with itself. We can do whatever it wants, but the brow is going to be in a position that we like. And it's been very effective. It works very well. Now, again, I want to repeat, it's not the only technique I use, but I have found it to be very useful.
Now, I might be taking us down an incorrect path here. Let me know if I am. But you talked about suturing and then taking out the stitches after a couple of days. Is that the kind of the theory behind a hemostatic net, or no? Different discussion.
Yeah, no, it is the hemostatic net. That's why I mentioned Andre Auerswald. So Andre Auerswald came up with the hemostatic net way back in like 2012, but it didn't really catch on until the last few years. And basically, what he proved is that you can advance skin, tissues in general, and if you sew them down, you are far less likely to get a hematoma that's bleeding underneath the skin, which happens 2.5% of the time in facelifts, 5% of the time in male facelifts. And so it's a valuable technique. But what started to happen as we were watching these things is that we also think that those tissues that were sewn down, each one of those little suture areas acts like a spot weld, and the tissues start to stick in that zone, which is why Fausto Viterbo in Brazil turned around and said, well, why can't we use that in the brow area? And that's where he came up with the concept of the gliding brow lift. So he's separating the skin from the muscle, elevating it, and then sewing it back down to a new set point. And it works very, very well.
Amazing. And, it just looks so scary. When I started seeing that, I only started seeing them online like a few months ago. And I thought, what is that? And why does it not cause any kind of scar?
So your body starts to deposit collagen around those stitches around 5 days later. So you've got a few days to play with. You got a few days for things to start to stick and stay in position. And it really does work very well. I haven't had any of them leave marks. And to your point, yes, when I first saw it, I know when it was January 2020. I thought to myself, what are you, crazy? I could never do that in New York City. I'll be running out of town. I'll never get another facelift patient again. And frankly, I had to go to a lot of boutique meetings, and I did, there's a lot of foreign trained surgeons at a lot of these. And they started to tell me, no, you got to try this. You don't understand what you're missing. One guy told me that he doesn't worry about hematomas, about bleeding after a facelift at all anymore. In fact, he did a facelift, put the net on, and got on the plane. He was just not worried about the patient. And I thought, wow, that's pretty crazy. I would never do such a thing. But just for the sake of being able to sleep at night and not worry about the patient was very satisfying. So I slowly started to back into it. I started to do a little bit on like the neck area in a small zone if I was doing a neck lift, that sort of thing. And when I proved to myself that there were no marks left, then I moved on to like different skin types and such. I actually had this conversation with Auerswald, and I explained to him, I'm in New York City. I treat every type of skin under the sun. I cannot afford to have stitch marks show up. And he looked at me and he kind of chuckled to himself and he said, Tom, I'm in Brazil. Are you kidding? Do you know what the skin I deal with? No, trust me, it won't leave a mark. Just go ahead and try it. So I did. He was right. It's fine.
Amazing. Is there a skin type that maybe you think, oh, I might not do the hemostatic nut, or no,
Not
just take
anymore. And well, not anymore. I might have hesitated in the past with type 4 skin. Sometimes people talk about African Americans are always concerned they don't want marks. I get it. Asians, same thing, but I haven't had a problem with anybody yet.
Okay. Yeah. My friend is Asian and she will not touch, and she will not have anything done with her face. um, so patient selection for a brow lift is how much more important is that than the technique itself?
Yeah, and that's a good question. I suppose you're right. I think that there are so many different ways to do things in plastic surgery. If you have 10 plastic surgeons and you ask opinions, you're going to get 45, 50 different opinions because there's just so many right answers. So I think that any of these techniques, if done well, can give stellar results.
So, okay, as you said, most patients don't even understand that a brow lift would give them the results as compared to, an upper cleft. What questions could they ask to understand if that would give them a better result?
Look, sometimes they're afraid of looking surprised for the rest of their life. Um, they might want to ask, what happens if my brow is too high? Can you lower it? The answer is yes. Um, Again, they might want to ask things like, how many of these have you done? Uh, they might want to ask more about the technique, um, those kinds of questions. But if you're going to a surgeon and you see their results, you say, "Look, show me someone else who resembles me to some extent. What does their brow lift look like?" That's probably the best question.
And should all surgeons just have a portfolio of photos, whether they're online or they're in their office? Is that something that should just exist?
Yes, it should. The problem, of course, is privacy and rights, and patients have rights. I if I was doing kitchens and baths, I'd have a thousand times more photos than I do that are available for people to see. But it's their face, and not everybody is willing to let me show their pictures to future patients, um, which I understand to a certain extent. Um, but they do have that privilege. I can't tell you how many patients come in when I'm taking preoperative photographs just to document where we're starting. They'll say to me, no pictures. I don't want them online. I don't want this. I don't want that. And I have to explain to them the HIPAA laws and let them know, no, this is in your private file. No one will ever see them unless I someday ask you for permission and you sign them off to me. But otherwise, everybody on my website, everybody whose pictures are in my office, I have permission to show those.
It's such a wonderful thing for a patient to agree to that. I mean, it's such a personal thing where I think I probably wouldn't have shared my photos, but would that have helped somebody else in the future make a decision that was, they needed those photos for some reason?
Yeah, exactly.
Beauty seekers, here's what we just learned. Dropped brow is often misread as an eyelid problem. And the original endoscopic approach failed because surgeons were not releasing one specific structure, the New York ligament. And when that changed, the results changed. Dr. Sterry, patients who had a brow lift that fell now know why one ligament was left unattached. Before a beauty seeker books a brow lift, do you think it's wise to ask candidate surgeons if they release the New York ligament?
Well, I don't know that I would ask it quite that way, but but yeah, look, again, it is technique dependent. So if you're having an endoscopic brow lift, um, you should be confident that your surgeon is going to do a complete release all the way across. and asking the question is fair. And an honest surgeon, well, explain his technique. As I mentioned, there are other techniques where that's not even on the table. It's not an issue whatsoever. So sometimes if it's a skin only or a gliding brow lift, you don't have to even ask the question.
Okay. And that's a tough thing. I'm glad you said I wouldn't ask it just like that because as a patient, you know, uh, I, I totally respect the amount of schooling and education and background that a surgeon has. So where do we, kind of where does educating myself kind of pause and then trusting this person that I really probably have just met?
Fair. I'm in a very strange business. I mean, people come in, they chat with me for 20 minutes, and then they're willing to lay down on a table and let me take something sharp and do some very impressive things. So, yeah, you're right. But they have to ask that they really do need to know. They deserve to know what they're getting into.
Beauty Seekers, thank you for being part of this community. Every subscriber is how we keep bringing you surgeons like Dr. Sterry, who explains the why, not just the what. Dr. Sterry, tell me about, please, a midface or a cheek case that again really stayed with you, a patient whose result taught you something about what the area of this face demands.
Uh, yeah, look, I think that in this zone, it's really all about getting a release of the zygomatic ligament, which sort of is a fibrous attachment of the soft tissues and basically the skin down to the elbow of the cheekbone right here. And you're not really able to get a nice lift in this zone unless you release that first, and then suddenly you get this big aha moment, and the whole cheek starts to elevate and lift for you, and it becomes free, and it becomes obvious that this is what we're trying to achieve. In the operating room, we'll be moving things around and doing our dissection and working really hard to stay safe. And then we check once in a while to see if we're fully released. When you finally get the last bit of that ligament, because it's very ill defined, by the way, it's not like something you can see. It's not like like your Achilles tendon or something like that. It's very hard to distinguish. When you finally get that release, it's really a dramatic whoosh of the tissues. And it's the way I believe that you're able to make people look natural because you're sort of putting the architecture of the face back to where it was when they were much younger, and then you just stabilize it there. Uh, these procedures nowadays are far, in my opinion, they're far better and far more natural looking than they were 20 years ago.
Wow. Okay. So you don't necessarily always see that final release. Honestly, of the interviews that I've done, this is the most I've heard about. You have to have a release before you can pull. And I really appreciate you educating us on that. So, but you just feel this release. It's kind of the skin moves or
Yeah, there's no doubt. Most of us, and it's funny that no one else has mentioned it. Most of us will put a couple of Alice clamps on the smashed tissue, and you sort of want to see how much you've advanced, and are you getting what you want yet? Because you want it to move superiorly and laterally without effort. It should just glide. It should just sort of go where you want it to go. If you've got to pull it tight, then that's wrong. It's not fully released. It literally just sort of flows superiorly and laterally off to over the cheekbone, and then okay, that's so much better. And when you're looking at the patient on the table, you can tell, wow, she looks great. And you compare the left cheek with the right cheek, and you can see the difference. And uh, you know, you make sure it's cosmetically pleasing.
this is like truly, it's like sculpture.
But this part of it is actually, yeah. I don't usually use those esoteric ideas, but yeah, yeah, they kind of do.
Dr. Sterry holds a patent for a surgical retractor he designed himself and has been asked by fellow surgeons to author 2 textbook chapters on body contouring. Coming up, he's going to tell us what the midface actually requires to get a meaningful result and what most patients do not hear in a consultation. And at the very end, he's going to share something honest about one approach to this area that most surgeons don't say out loud. Dr. Sterry, welcome back to Beauty Seat.
Thanks so much.
The mid-face, the cheeks, the nasolabial folds is it's where a lot of visible aging happens. On a scale of 1 to 10, how significant is mid-face descent in the overall appearance of aging?
Oh, gee, it's hard to put it in terms of a scale of 1 to 10, but it's at least 5 or 6, I think. But as we age, we know that the fatty tissues and the fullness that used to be up here in our right over our cheekbone sort of descends, which is what contributes to the encroachment and the deepening of the nasolabial fold. It also means that some of the fullness that was in our cheek, like the apple of the cheek, as it descends, it sort of becomes a jowl. So yeah, these are significant changes that happen. So putting things back up superiorly, and by the way, we also know that we lose bony tissue and we also lose some of the soft tissue as we age. So a little fat grafting is helpful, but as we advance and put things back where they sort of belong, my mother always told me put that where you found it, put that back where it belongs. You put it back up where it belongs, you enhance it maybe with some fat grafting, you get a very nice outcome, much more youthful.
A traditional mid-face lift, otherwise known as open surgery, which I'm hoping you can share a few more details of that. It has a known track record. On a scale of 1 to 10, how reliable are the long-term results of traditional open mid-face approaches?
Well, I think if you're in traditional open mid-face approaches, gee, that's a tough one. There are so many of them. There's the subperiosteal mid-face lift. There's so many different techniques. Um, I think I would divide it up a little bit differently. I'd talk about SMAS imbrication and SMASectomy, which is so the SMAS is the fibrofatty tissue, the connective tissues in the cheek here, and we're all trying to find ways to advance it, put it back, as I say, where it belongs, to get it to stay there. So there are many people who will just put some stitches from the lower portion of the face up to a more fixed position and try to pull things up. And then they hope that they stay there after they close the skin. And you know what? Some of them don't look bad at all. Now, their longevity probably doesn't hold up as well. These are hard to get good studies on, by the way. Um, but sometimes if it's done well, they look pretty damn good. It's hard to argue with that. Um, the more 2026 version is where we actually go underneath those layers. We go sub-SMAT, we're going underneath that connective tissue in an area that is a little bit more treacherous. It's a little bit more murky because there's some soft tissues mixed in with some nerves that we don't want to injure. You got to be very careful. But when we release that zygomatic ligament, there's a couple of other ligaments, by the way, but that's the main one. And then we advance those tissues up and fix them in place. I think we're having, in my hands at least, I'm getting much more longevity and a much more natural look. Am I answering your question?
Yeah, it's hard to know, as a beauty seeker, when we're trying to understand, should I lean towards this new technique? Has it proven? Is it going to last? Well, this other technique, I'm hearing it lasts a long time. How do we know where to go?
Yeah, look, the consumers are kind of stuck, right? Not knowing how much of this is spin and how much of it is marketing, et cetera. I can tell you that I tinkered around with just about just about every facelift technique that there is, and I choose to do the deep plane because I think my results are better and longer lasting. It is arduous. It takes in my hands it's 5 or 6 hours. It's very tedious, but I do it because I think the outcomes are better. I think the patients look more beautiful. I think that they I'm more proud of the work when I walk out of the operating room and when they come back in for post-operative photos, etc. It really makes me very happy. Each one of these folks is my own little, creation sort of, and I want them to look great. I want them to look like them. And I want it to hold up. I want them to tell their friends when their friends say, "Gosh, you look great. You're aging so gracefully. How do you do it?" I want them to give them my name. Like, what? I want to be that person.
Exactly. And that's what we do. We talk and we share. Perfect. Many of the surgeons that I've interviewed, they've spoken about cadaver training, which totally I'm totally into something like that. They, the ones that spend time in the anatomy lab, and they're, kind of testing how surgical techniques could evolve. On a scale of 1 to 10, how important do you think that kind of training is for surgeons who want to push more into, I don't know, complex or newer techniques?
I think that's an 11 out of 10. You know, look, I finished training in 2001. Things have changed since then. And if you don't, if you're not moving, you're stagnant. And I really think that you've got to go back and continue to refine your skills and refresh and learn new things. And I don't want to practice the first time on a live patient. So, the cadaver lab, as I don't mind telling you, it's not something that I relish. It's sometimes very disturbing, but I appreciate what that person, the cadaver, is offering me, and I try to make the most of it. Without those labs, I think I've been the best lab I'm aware of happens to be in St. Louis. I've been there, I think, 5 times. Um, I learned something new every single time, and just appreciate it. It's one thing when you see something on paper, in a textbook, or if you're watching a video, that's still only 2 dimensional. Even a live video, right? It's still 2 dimensional. When you are in the lab and you see, oh my gosh, look how close, when I do this technique, look how close I am to structure A, B, C, D. The last time I was down there, I realized just how close I was to the facial vein when I'm doing the submandibular gland. These labs are terrific. I think they're key. They're uber important. I can't say it enough.
I love that. So I'm a donor. I have a donor on my license. Does that mean I could end up be a donor for anything?
No, I think when you're a donor, you're an organ donor. I believe that's not donating your body. I think your family does that. I think when you're an organ donor, it means that if somebody needs a liver, they can use your liver if you're not with us anymore.
Oh, okay, great. Okay. I'm gonna have to dig into that a little bit more because I was just also learning about donating fat. That some surgeons are doing fat transfer with cadaver fat.
That's the newest thing. That's called alloclade. There's a couple products, but alloclade is the one that I'm more familiar with.
Oh, great. Are you doing that?
I've only used it one time actually, but I gotta tell you, it was great. It was really simple, so easy. Patients incredibly happy. Yeah, I could see using something like that again. Sure.
Could you just touch on that just quickly, just so, because this is so new, I would love to just get an explanation to the beauty community. What is it? Why would you use it?
So let's say let's say you are a very slim person and you want a little more booty. Um, we can't do a Brazilian butt lift on you. That's where we borrow fat from one area and we inject it into the buttock area because you don't have a donor site. There's no place to borrow it from. Or let's say um, you had liposuction and you had a problem and you got a little bit of a groove or a dent and you just want to fix that. The best way to do it is with fat, of course. So to have the ability to take something off the shelf and in a matter of minutes have it injected with almost no pain, no big ordeal, no anesthesia, big bang boom. It's a pretty great concept. Um, Now, I thought it was kind of gross when I first heard it, but the truth is, I had to stop myself because I had my neck fused a few years ago, and they used banked bone to fuse my neck. How is this any different, really? Sure, you might argue it's a little bit more frivolous, right? Without fixing my neck, but um, it's still the same concept.
Perfect. Thank you. Great. I'm excited to dig deeper into that. Okay. Back to midface. If a patient is considering midface surgery, is there a question that they should be asking their surgeon, which when you're in consults with them, they really never think to ask, but they should know this answer?
Yeah, I would want to know what their approach is for the mid face. Are they going into the deep plane? Would there be fat grafting involved, and how much fat grafting? Because again, there's never any one right technique, but I would want to know how much are you relying on fat grafting? Because we know that that can be, frankly, unreliable. Um, I'd like to know how they're planning to advance and suspend the midface. I'm, for instance, as a surgeon, I'm not a huge fan of cable sutures. That's where you sort of run a stitch from this area and you sew it way over here. So there's a spanning stitch in between. Usually, if we want reliable work done, you put a stitch in and you tie a knot kind of like you tie your shoe, and you expect it to advance and the knot's right there. And we believe that we have better luck with that kind of suturing than with cable sutures. Um, so yeah, I would want to know a few of those.
Okay, perfect. Can you just explain endoscopic facelifts for our community?
Yeah, it's really a very innovative area, and it is on the rise. Everybody's talking about it. Everybody wants to learn about it. Essentially, we're starting to figure out ways to get down into the midface here or way up near the brow, with the brow inside the hairline incision, and do a pretty good job of lifting the midface and getting it to stay there. We then, once that's done, as I mentioned a minute ago, we can come from behind the ear with the scope and into the lower portion of the face and also free up that tissue. So um, it takes a while. It's a little bit tedious. It's arduous, but you know what? It's doable. And some of the results I'm seeing and that people are getting are very, very impressive. This area reminds me of when I was in medical school in the 90s and the laparoscopic cholecystectomy was coming out. That is a laparoscopic approach to taking out a gallbladder. And some of the old timers didn't want to learn. They kept claiming it was unsafe. There were all kinds of heated arguments at our conferences and things. I'll never forget it. And of course, as you know now, nobody would ever open up the old-fashioned way to take out a gallbladder. Why would you give the patient that big long star? Uh, it was just a matter of getting the instrumentation right and getting the training right so that people could approach the gallbladder from a different area. And I think that the face is the exact thing, just lather, rinse, repeat. It's the whole argument all over again. There are people saying it's not safe. There are people saying it's not efficient. You're not going to be able to get a good polo. You're not going to get a realistic outcome. I think, until you've trained in it and you've experienced it for yourself, I don't really think you should be making statements like that. It's a really exciting area. And I personally am beginning to get my own training in.
And the big benefit is what's the biggest benefit of doing endoscopic?
So one of the stigmata of having a facelift is an incision around the ear, in the front of the ear. And we can completely avoid that. We can also avoid incisions near the hairline, in the brow and such. So it's almost invisible, very hard to track it down. And as I say, for the right person, we really are beginning to get very impressive outcomes.
Wow. I mean, the tech is amazing. Have you seen like the technology itself improve?
Yeah. Yeah, in a couple of different ways. It's got to do with the endoscopes themselves. Um, Silly things that you wouldn't think matter. The type of scissor for dissecting, the spreading instruments that we have, and some of the techniques we use to not just elevate but to hold things in place. There are some ribbons and things that we're using nowadays that are very, very effective. And I personally, I think it's a big wave. There's no point in trying to fight the tide. It's coming, and so that's why I'm trying to get trained.
And what an exciting time. And I love that there are surgeons who, we're about the same age. We were trained in whatever our skill, we went to school for in the 90s. And now we're getting retrained again on the most modern technology, like me, AI, and you just these amazing tools.
Yeah, I completely agree. It's a good comparison.
Perfect. Okay. Beauty Seekers, here's what you just learned. Mid-face lifts have decades of results behind it. Surgeons know what to expect at 5 years and 10 years because they've seen it. Dr. Sterry, of everything we've just discussed today, neck, brow, mid-face, what is the one area of the face where you're not ready to tell a patient that endoscopic approach will hold up long-term?
I think for the mid face, we still don't know for sure how long the endoscopic lift is going to last. I, I don't mean disrespect to my colleagues because I have I have friends and I know people who I respect immensely who seem to get outstanding results, which is why I'm so intrigued by the area. But I'm so intrigued. I'm trying to get my training currently. But as I say, I don't think that we really have results, 10 years later. Uh, we don't have studies that proves that these techniques are going to hold up. We see results that they like post 3 months, 6 months later. But I'd like to see some results a couple of years later. I'd like to see some comparisons, some actual science. So actually, in my mind, the jury is still out. I'm pursuing the training. I'm incredibly curious. I think it's a very exciting area, but I'm not necessarily sold on it yet.
So then just to clarify, there are studies that show longevity of endoscopic brow lift or a neck lift, just not the mid face.
Yeah, I don't think there are as many and as widespread. They don't have the same scientific power as some of the other stuff. Only because they're newish, right? We haven't really been doing them, that many of them for that long.
Okay, that's fair, and that's what I would want to be told if I was considering a mid face. You're kind of taking a gamble, I guess, right? It's great initial results, and we just don't know for sure if it's going to last.
Well, yeah, we don't know the longevity. I mean, look, the folks who want the endoscopic facelift, well, they're really trying to avoid the stigma of having an incision near the ear, in the front of the ear. And I absolutely understand that. I do. I Now, usually that scar is really good anyway, but I understand. Uh, and they're usually willing to accept that it may not last as long. Maybe it will. We just don't know yet.
Beauty Seekers, Dr. Sterry is not yet convinced that endoscopic mid-face surgery will deliver long-term results comparable to traditional approaches. Whether the fixation holds 5 years, 10 years, the plastic surgery industry just really does not yet know. He's performing cases, he's watching it carefully, and he respects the surgeons doing it. But what I'm hearing, Dr. Sterry, is that you would not tell a patient that an endoscopic midface is proven to last the way a deep plane facelift.
Yeah, I think I'm comfortable with that. Yes, I agree.
Okay. Thank you. Dr. Sterry, you walked us through 3 areas of the face today, the neck, the midface, the brow, and we learned so much about what an endoscopic surgery is and the questions that we need to ask as beauty seekers with respect to our surgeons so that we can make the best decisions for us. That's what a true craftsman sounds like, and I appreciate your candor. Thank you for being here on Beauty Seek.
Thanks so much for having me. This was a lot of fun.
Beauty seekers, from the bottom of our hearts, thank you, not just for watching, for being part of a community that believes you deserve to know what surgical techniques work, which ones are still being proven, and what questions to ask before you book a surgery. Every subscriber is how we keep bringing you physicians like Dr. Sterry, the ones who tell you their truth. Thank you.
And when people say, I'm a cosmetic surgeon, I only do cosmetic surgery, that could be anybody or cosmetic surgery. And that could be anybody. That could be a dermatologist, internal medicine, OB-GYN, psychiatrist, anybody. And part of their certification is they have their own standards, but obviously they're different than what we have for plastic surgery.